Professor Lee, I'm going to ask you about the developing knowledge of risk of non-A, non-B hepatitis is the next topic. But first of all, as part of your general medical training and then your haematology training, what do you recall you learnt about the risks of viral transmission from blood and blood products?
Sorry, the risk of?
The risks of transmission of viruses through blood and blood products. To what extent did that feature in your medical training?
Well, getting back to when I was a house officer, a medical student at the Radcliffe at Oxford, Professor Paul Beeson was the professor of medicine, and I remember very distinctly going on ward rounds, almost the first ward round we went with him as a student. He asked us what the risks of blood transfusion are. And we very quickly learnt to say hepatitis. And, of course, the reason he focused on that was because he was, I said earlier, he was the man who in 1943, as probably a very junior doctor, had noticed that 7 patients he wrote up who'd become jaundiced, there seemed to be a common feature that it was due to transfusion. And he was the person at the end of that report that said that it was very important that doctors recognise this problem and recorded details of what they'd had transfused. I think, scientifically speaking, looking at it, you could argue, maybe it was hepatitis B, but it was probably more likely that it was non-A, non-B hepatitis. And of course, there were no tests at that time. So I suppose that was my first knowledge. Then, of course, the Australia Antigen, as it was called, was identified in 1965, and I remember this was the measure of hepatitis B. It was called Australia Antigen because it was first identified in Aboriginal people. And I can remember as a medical student, we had he's died now, we had a professor, he wasn't a professor, he was a gastroenterologist stroke hepatologist, Ralph Wright. And I can remember going with a bottle to get a patient's blood who'd come in when I was a house physician for access to this Australia Antigen, which he had in his laboratory. I think my knowledge, I think if I remember rightly, and maybe I don't need to remember the detail of this and we can revert to it, but the test for hepatitis B came in 1973. So by the time I did my blood transfusion training, which was 1979, I think I would have certainly been aware of hepatitis B, but of course by then we had a blood test for it. So, in terms of course I knew about hepatitis A because it's orally, it's a problem not necessarily from blood transfusion, although later it transpired that one of the concentrates transmitted it. I think non-A, non-B hepatitis, to be perfectly honest, I don't think I really was particularly aware of it until I was aware of this research post. I think that's probably true.
I'm going to ask you in a moment to look at a small number of papers from the 1970s. You may or may not have seen them at the time, but they're a set of articles that we've asked other clinical witnesses to look at so far. Before I do that, generally speaking, in the 1970s and 1980s, what journals or periodicals, magazines would you read in order to keep yourself up to date with medical developments?
I think, for the most part, in that time, I would more read textbooks. There was a particular volume for haematology called Postgraduate Haematology that was the sort of Bible, if you like, for MRC Path. In terms of journals, I mean, my husband and I have a life subscription to New England Journal, so that would have been in the house. British Medical Journal was also in the house that I would have read. Lancet also, we took Lancet at home, I think. And in terms of other relevant journals for haematology, I would have read British Journal of Haematology. That would have been in the library at St George's Hospital. Again, I think what's really changed so much over this time is you had to go to paper journals. I mean, now you just go straight into the internet and can find anything. And the other thing, I suppose, is really the delay in publication. So sometimes you would rely on hearing things at meetings, and sometimes there would be departmental meetings. But it wasn't really very focused, really. When I did blood transfusion, I think hepatitis B I would have really known about, and hepatitis A to a certain extent. But that was it. I mean, I think the other thing just to say about blood transfusion, when we did our training in blood transfusion, a lot of it was on the basis of doing the laboratory things, of looking at antibodies and antigens. You had to identify whether somebody had an antibody to certain blood antigens. That was quite complicated, and we spent a lot of time doing that. So I think...
Okay. You've already indicated, I think, in the responses you gave this morning and just now that it had generally been known, certainly from the 1940s onwards, that hepatitis was a major risk of blood transfusion. I'm going to ask you to look at it's 4 or 5 short articles. If we could first of all please have Henry, PRSE 0001431. And I'm going to show these to you, or extracts from them. They're all fairly short, Professor Lee, and then ask you some questions about them. So the first is a Lancet article from August of 1974. It's long incubation post-transfusion hepatitis without serological evidence of exposure to hepatitis B virus. And there are just 2 passages, I think, that will suffice for current purposes. The summary explains that an agent other than hepatitis B virus seems to be the cause of 71% of 51 cases of post-transfusion hepatitis identified during prospective biweekly serological follow-up of 204 cardiovascular surgery patients. The sera of the 36 cases showed no evidence of the antigen or antibody response expected to accompany infection by HB virus and to be detectable by the sensitive assays used. Incubation periods and clinical and epidemiological features were inconsistent with hepatitis A. Cytomegalovirus-associated seroconversion was no more common among the HB negative cases than among HB positive cases or among patients who did not develop hepatitis. The data suggest that a large proportion of long incubation post-transfusion hepatitis is unrelated to hepatitis B, and that control of post-transfusion hepatitis will require identification of a hepatitis viruses type C. And then if we just go to the last page of this, please, Henry. Left-hand column towards the top of the page, the first main paragraph beginning the fact that non-B hepatitis cases are less frequently associated with serious acute illness does not imply that such cases are of lesser importance. Long-term complications of acute hepatitis B infection, such as chronic hepatitis, cirrhosis and hepatoma, have been reported to follow mild and icteric infections more frequently than severe icteric cases. Consideration must then thus be given to the possibility that non-B hepatitis may play a role in the etiology of some forms of chronic liver disease. Pausing there, Professor Lee. First of all, I'm not expecting you necessarily to remember if you read this at the time, but would you have been reading The Lancet at the time? Is this the kind of material you're likely to have come across in 1974?
I think no is the answer, because I was just reviewing my CV and trying to... In 1972 to 73, I was a research registrar in renal medicine to now Sir Keith Peters. And then, for domestic reasons really, I left that post. I had an MRC training fellowship, but I left that post to work as a general practitioner because I thought that would fit in with my domestic responsibilities. I think it's very important, and this is in the College of Physicians recordings that I made, which were essentially to look at how women went into medicine in that period, 60s, early 70s. There was no opportunity, really, to have children in creches or nurseries and things. And so my husband and I felt that it might be a better career path for me. And I actually trained in general practice for a year until September 1974. And then I realized that general practice wasn't for me. I'm very privileged to have had that experience because I think it helped me understand people and patients and other concerns. I went back into my first love, really, which was haematology, because before I went to university, I'd worked for 8 months in the postgraduate medical school in a haematology laboratory. So I went into haematology, and that was when I started at Harrow Road, so St Mary's Hospital, Harrow Road, with Dr. Jack Fielding. And that was a district general hospital. September 1974. I don't think we had any patients with haemophilia. And I certainly would not have been aware of that article then. But I know the article, and I think, became aware of it when I took up the research post in 1983. I think it's also important for me to remember and to let people know what the knowledge was around about that time. I was a senior registrar, part-time senior registrar at St George's, and then I said I'm going to take this post to look at non-A, non-B hepatitis. And amongst my colleagues, there was almost a universal thing. What is that? Why are you doing that? So, to answer your question, I probably became first aware of this paper when I took up the research, because it's a very significant paper. But up until then, I would not have seen it. and probably very few of my colleagues would have been aware of it.
Well, I understand the basis for the first part of your answer, Professor Lee, that you wouldn't have seen it at the time. What's the basis for your suggestion that your colleagues in haematology would not have seen it at the time?
The basis is my personal memory of when I said I was leaving to go and do this research. So I'm talking about the group of doctors that I worked with at a very significant department of haematology, headed by somebody who specialised in hemostasis.
You've rightly said this was a significant piece of work, something which you realised later. It's significant because it's one of the first articles which identifies the existence of what then over the next few years became referred to as non-A, non-B hepatitis, isn't it? So that's its key significance, that this is the emergence of non-A, non-B hepatitis and an understanding that there was some other form of post-transfusion hepatitis. Would you agree?
Yes.
And the second part of its significance is that observation or warning on the last page that I'm going to paraphrase and put it in perhaps more colloquial terms, that clinicians shouldn't assume that non-A, non-B hepatitis is going to be something mild or insignificant. Would you agree?
Well, I agree what's written there, yes.
If we could then have up on screen, please, Henry, PRSE 0001794. This is an article by Krask, Dilling and Stern in August of 1975 in The Lancet, an outbreak of hepatitis associated with intravenous injection of factor VIII concentrate. We can just, again, look at two passages. I think this is one, again, that you're familiar with, Professor Lee. So the summary tells us that there was an outbreak of jaundice associated with 3 out of 4 batches of a commercial brand of freeze-dried factor VIII concentrate at the Bournemouth Haemophilia Centre between April and June 1974. 7 cases of non-B hepatitis, 4 of hepatitis B occurred within 6 months of the first use of this product. 2 patients contracted both types of hepatitis. 9 became ill out of a total of 20 regularly seen at the centre, 18 of whom received commercial factor VIII concentrate. So here we have a report of non-B hepatitis in Hemophiliacs, published in The Lancet. And if we go on, please, Henry, to page 3, we look towards in the left-hand column, second half of the page, actually towards the bottom of the page, please, Henry, the paragraphs numbered 1, 2 and 3. We can see that Dr. Krask and his colleagues say this: in the meantime, some or all of the following measures might help to lessen the frequency of jaundice. Commercial factor VIII concentrates should be reserved for the treatment of life-threatening bleeds in all haemophiliacs and for covering major operations. And then it goes on to make 2 other observations. Is this an article which you think came to your attention at the time?
No, in 1975, I think. Wasn't it?
Yes, it's
No,
August of 1975.
In 1975, I was working for Jack Fielding, I think, and I was also pregnant with our first son, and I don't think I would have been aware of this article then. I certainly, of course, became aware of it as soon as I started looking at this problem. And again, I would remind you, in 1975, I think that was when Catherine Dormandy was in charge of haemophilia.
Yes.
And of course, if you read, if subsequently I read her articles, and it was quite clear that she must have been aware of that, and she must also, because she wrote that paper where she compared the rate of transaminitis in her patients treated with cryoprecipitate and the American. But I certainly wasn't aware of this paper in 1975.
And I absolutely understand that, Professor Lee. I'm trying to explore these papers to some extent generally with you, but drawing on the fact that you subsequently specialised in haemophilia. Would you agree that this is a report that ought to have been given serious consideration by those caring for patients with bleeding disorders in 1975?
I don't know, really. I don't think I can comment. I think what it says, I agree with. The question you're asking me is whether everybody caring for people with bleeding disorders would have known this. I don't know. I wasn't involved in that at that time.
Yes, my question is not whether they would have known it as a matter of fact, because obviously you can't speak to that, but whether you would accept that they should have known it. This was a significant publication in terms of haemophilia and non-A, non-B hepatitis.
I think that's probably right. But I think it's very difficult for me to comment on those people at that time because, knowledge moves. And I don't know how long, this kind of information might have been presented at meetings. I don't know. I wasn't at those meetings.
No, and we have access to meetings such as those of UKHCDO. Do you recall whether later, once this became an issue that you were going to be researching with Dr. Kernoff, do you recall ever discussing with him the recommendation that we see here from Dr. Krask and others, that commercial factor VIII concentrate should be reserved for the treatment of life-threatening bleeds and for covering major operations?
I don't remember specifically discussing it with him because, as I said, my responsibilities were not in deciding what should happen. It was trying to find out what was happening at that time.
If we could then have, please, PRSE 0000381. This is a publication in the Yale Journal of Biology and Medicine in 1976 by Purcell, Alter and Dienstag. If we just turn, please, Henry, to page 246. So it's the fourth page. It's just one passage I wanted to invite your attention to, Professor Lee. And we see by this time the terminology of non-A, non-B hepatitis is being used. Third paragraph or so down, although type non-A, non-B hepatitis is associated with less severe acute illness than type B disease, then long-term prognosis for the two diseases may be similar. And then the passage goes on to discuss transaminase elevations. I just invite you perhaps to read that to yourself, Professor Lee, and then I'm going to pick it up in the last sentence of that paragraph. Chronic non-A, non-B hepatitis is not necessarily a benign infection and may be the cause of a significant proportion of chronic hepatitis.
I haven't got that.
I'm so sorry, Professor Lee, I'm going too fast. So that others can follow, I'll read the whole passage. Thus, elevation of transaminase values persisting for 6 or more months has been observed more frequently following non-A, non-B hepatitis than following type B hepatitis. Others have reported similar results. Transaminase elevations have been documented for several years in some patients. 3 such patients at the NIH underwent liver biopsy. 2 had histopathologic changes in the liver compatible with chronic active hepatitis, and the other was diagnosed as having chronic persistent hepatitis. Thus, chronic non-A, non-B hepatitis is not necessarily a benign infection and may be the cause of a significant proportion of chronic hepatitis not identifiable as type B disease. This is a publication 1976. I'm afraid I don't know the month without...
Well, it was a bit of a publication in February. That
Yes.
is best we can do.
Yes, I'm sure we can find the precise date, but in any event, it's published in the Yale Journal of Biology and Medicine. 1976, I think, was the year you moved to St George's, but you've described the broad nature of the work you undertook there. Do you think you would have come across this article at the time?
1976 is a very significant time in my life because our eldest son was born in 1976. And I was on maternity leave, and I spent the time trying to negotiate a part-time post. I had no job, and in those days it was quite difficult if you wanted to have a part-time post. And I think I eventually started at St George's Hospital on October the 14th, 1976. So I certainly was not aware of this paper then, but I did become aware of it, of course, because it's a very significant paper, and I knew Harvey Alter eventually, and I think this last sentence is very important. It says, thus chronic non-A, non-B hepatitis is not necessarily a benign infection and may be the cause of a significant proportion of chronic hepatitis not identifiable as type B disease. The significant word is may. And the whole point of studying this, there was no test, was to find out more about it. I mean, the whole, all people at that time, and this was knowledge that I would have, become aware of as I started doing the putting the data together. People were aware of these transaminitises. There was an idea that it might be some kind of metallic thing in the concentrates, but they were aware of the transaminitis, but the knowledge of what was going to happen was just not there. Indeed, even the acute infection, until we published our very detailed follow-up, the what happened when you have an infection was not so clearly defined. A lot of people who had their first attack, it was asymptomatic, and as I think I said earlier, the only way at the time that we were doing this to prove as best you could that somebody had it was to do sequential transaminases and to have a baseline. You needed to know what the level was before somebody had the treatment. And of course, we didn't know the long-term consequences really until I would suggest the knowledge didn't really become defined as to long-term consequences until the 1990s, and perhaps our long-term study in 2000 actually was very significant, because what it showed was that for people who didn't have HIV co-infection, the progression rate was very slow. So I hope that answers your question.
Yes. Would you agree that whilst you're right to point out the use of may and to observe that there was still much that was unknown?
Yes.
Would you agree that, again, for clinicians practicing in the field by 1976, this, from a very authoritative source, should have been at the very least a warning against any assumption that non-A, non-B hepatitis was somehow mild or insignificant?
No.
Why?
Because I don't think they would have read this journal. Well, sorry, this is the Lancet one.
No, this is the Yale Journal of
Yes.
Biology and Medicine.
I mean, I doubt whether any anybody in this country reads the Yale Journal, I don't think they would have been aware of this.
How would important research such as this from the States have been disseminated in the United Kingdom then in the late 1970s?
I would think that somebody like Dame Sheila Sherlock would have probably attended the American Association meetings of hepatology. That's probably how it would have got disseminated. But I don't think this would necessarily have been disseminated amongst haemophilia physicians, this particular paper.
Let's look at one more from Harvey Alter, which is now the following year, 1977. Henry, this is NHBT 000092_002, please. This is headed International Forum. It's published in Voxang 32, so in 1977, and it appears to be an address by Harvey Alter. I'm just going to ask you to go to the end of it. So the second page, please, Henry. Last paragraph of the paper, so the bottom right-hand column. Although non-A, non-B hepatitis is, on the average, less acutely severe than type B hepatitis, it can cause severe acute disease, and more disturbing, it appears to have considerable propensity to progress to chronic hepatitis. And then he says, the main thrust of post-transfusion hepatitis research must now be directed at developing detection methods for the non-A, non-B agent, or developing some reliable method of viral inactivation or removal, which would be independent of testing. Were you familiar, first of all, with this journal?
Sorry, what was the journal?
So if you go to the first page, it's Voxang.
No, I didn't read Voxang.
Would you expect haematologists to be broadly familiar with research or
in 1977,
advice of this kind?
I doubt not every haematologist would have read Voxang. I think it might be quite helpful, if I'm allowed, for us to, am I allowed to do this? To help answer these questions about what people were thinking and what they knew around this time, because, you know, it was 1977. I wasn't moving in these circles.
No, but I'm very keen to keep this chronological, Professor Lee. So
yes, but can I...
Materials from the 1970s, yeah, absolutely.
I just... You've had this article, and I just feel it's important for people to get a feel for what people knew and didn't know. Haematologists, I'm talking about, and haemophilia physicians. In fact, the person who's contributed the most to haemophilia care in the whole world, I would say, and that's Professor Pierre Minucci, who's now 80. And you have this. Can I?
Yes, what's the reference, please, Professor?
The reference is witness 755071, and it.
So that reference will have changed. Could you give me the title of it?
It's AIDS, Hepatitis and Haemophilia in the 1980s, Memoirs from an Insider.
If you give me a moment, Professor Lee, I know we have it, but it's not necessarily under that
I may be able
reference.
to give you a different reference that is, your references are all different.
It's WITN 0644071, please, Henry.
This is wonderful. Thank you very much. To answer your question, really, you were asking about what would you expect people to know. And I think what Minucci is writing here really encompasses it, really, that through the 1970s it was recognised that the use of concentrates, coagulation factors made from plasma pools, were associated with hepatitis. And then it goes on to talk about the first tests of liver function tests, and I think it quotes the Alter paper. And then I would just point you to the second page, the next page, and I think it's important that sentence that he writes, it was only in the mid-1970s it became clear that hepatitis was frequent in haemophiliacs, and it was only in the mid-80s that it was shown to be progressive and severe in 1/6 of patients.
If we look at it's right to note, this was an article written by Professor Minucci, I think in 2003, or published in 2003. I'm going to ask you some more about this later.
We've got the wrong one, that's why, is it?
Top of the first page, to cite this article, and then we see the date, 2003. But if we go to the second page, which you were referring to, Professor Lee, you'll see in the paragraph above there, he talks about a relatively benign picture of non-A, non-B hepatitis, initially emerging from studies, being questioned by 3 subsequent studies published in 1985 and 1986.
Yes.
The issue I'm exploring with you, or seeking to explore with you, Professor Lee, is whether it's right to characterise the understanding of non-A, non-B hepatitis in the second half of the 1970s as being a relatively benign condition.
I think for some people it was a benign condition. It probably was, and it was probably right to characterise it. I think the whole problem was that it was very difficult to sort out who was going to have a benign prognosis and who was going to have progress quickly to liver disease. And that only really evolved later.
We'll look at some of your latest studies in due course, Professor Lee, but if I can return you to the second half of the 1970s, there are just 2 further documents I'm going to ask you to look at. RLIT 0000228, please, Henry. This is a publication by Hufnagel and others called Transmission of Non-A, Non-B Hepatitis. And the date is 1977. This is from the Annals of Internal Medicine. If we could go, please, Henry, to page 6. It's the long paragraph in the right-hand column, beginning several clinical and epidemiologic features of non-A, non-B hepatitis. If we could just, thank you. So I'm just going to read certain parts of this, Professor Lee, and then ask you about it. Several clinical and epidemiologic features of non-A, non-B hepatitis have become clear from studies such as the present one. First, non-A, non-B hepatitis closely resembles type B hepatitis. The incubation period, the clinical symptoms and signs, and the potential for chronicity appear to be similar to type B hepatitis. Undoubtedly, what was once referred to as serum hepatitis included both type B and non-A, non-B hepatitis. So that's the first point. Second, non-A, non-B hepatitis appears to be spread predominantly by the parenteral route. Most cases have been described in association with transfusion, intravenous drug use, or serum inoculation. And then we can skip to the third point. Third, non-A, non-B hepatitis appears to be associated with a chronic carrier state and chronic liver disease. And then it goes on to talk about the particular study. The implicated blood donors were for the most part asymptomatic, although liver function tests and liver biopsy examinations frequently showed evidence of underlying chronic hepatitis. And then finally, non-A, non-B hepatitis appears to be common. 3 of the 5 infectious donors studied here transmitted this non-A, non-B hepatitis. And then it goes on to talk about the screening of blood donations. If we can just go a little further down, Henry. And then goes on to say that at the present time, more than 90% of post-transfusion hepatitis is due to non-A, non-B hepatitis. So, Professor Lee, this doesn't appear to be consistent with Professor Minucci's description of a benign picture in the 1970s of non-A, non-B hepatitis, does it?
Well, I would just comment, and I think we need to perhaps talk about the work that I did for with Dr. Kernoff and Dr. Thomas, and that is that certainly the acute attack in some of those patients was totally asymptomatic. And I would also like to fast forward to tell you that come the year 2000, so we're talking 30 years after, there was a very low number of people who had progression of their hepatitis in those who were not infected with HIV. HIV was a terrible co-infection that speeded up the progression of this condition. I think it's also quite difficult in 1977 to talk about progression when there is not a test. And in certain, I think it's very difficult. And you know, I think it's very important to understand that part of the rationale, if you like, of trying to understand what happened following concentrate treatment, which had been given because it was necessary, because the patient had some kind of life-threatening bleed or needed an operation or whatever, acute operation. It's important to understand that we needed to know what was happening, you know. And yeah. I don't. I've got a bit lost with your question, actually. I'm getting tired.
Would you like a break?
I think I probably would like a bit of a break, if that's possible. Just
just
5 minutes or something.
Or we could take the half-hour break now, sir. And
well, that will be a good idea, I think. It's not an endurance course, it's evidence. So by all means, if you feel tired, you must let us know, and you've done that. So take a break now for half an hour. Allow everyone to get a cup of tea, a bit earlier than usual, but that's what we'll do. So be back, please, at 3:20.